are ready, the anticoagulants are ready, but did you test your donor for TTIs? That is very important. What are TTIs? TTIs are transfusion-transmitted infections. TTIs are transfusion-transmitted infections, and these include for India. Remember, for India, you have to test for 5 things, just 5 things. And that includes HIV, which is going to include both the HIV, testing for HIV 1 and 2, hepatitis, hepatitis B, hepatitis C, malaria and syphilis. Repeating, HIV 1 and 2, hepatitis B and C, syphilis and malaria. These are the 5 testings which are mandatory. Not doing them is a legal offense. It is a crime. For not testing a donor and giving someone blood without testing for these 5 accounts for a medical legal case. It is negligence. So please remember, HIV 1 and 2, hepatitis B and C, malaria, syphilis. Rutlo, very, very, very important. On that note, the next thing, now your donation is done, bags have been prepared, storage temperatures are done, anticoagulants are done, testing is also done, everything is negative. You are now ready to give that blood to a patient. What are the transfusion protocols that you have to follow? Tell me, do you already know what is the size of the needle that you were using? 18 to 19 gauge, I have told you. Do you already know what is the micropore filter size? Again, I have told you it was 170 microns. So these parts you know. Now you just need to know what is the timing, what is for the transfusion protocol timing that I'm going to follow. So please note that, say for example, you're dealing with a red blood cell. Red blood cell ka bag tha, you removed it from where? Where is red blood cell stored? Red blood cell stored at 2 to 6 degrees centigrade in a refrigerator. You've removed it from the refrigerator. Within how many minutes should you start giving it to the patient? Within 30 minutes. Don't make it stay outside on the shelf for 2 hours and then you give. No. Remember, within 30 minutes, you have to give that to the patient. And within how much time are you going to complete that bag? That bag should be completely transfused to the patient within 4 hours. So within 30 minutes of removal from the refrigerator, the blood donation or the blood transfusion should start. And secondly, it should be completed within 4 hours if it is a red blood cell. If it is a platelet-rich plasma or a fresh frozen plasma, within 20, the speed of the bag is such that within 20 minutes, you should transfuse it to the patient. Just keep in mind, fresh frozen plasma ko pehle thaw kar lena. Fresh frozen plasma has come from a minus 30 degree environment. You're not going to give ice to the patient. You will thaw it, you will melt it, and then you will start transfusing it. But when you start transfusion, this should be completed within 20 minutes for PRP and FFP. And for RBC, the limit is going to be 4 hours. Now, what if you have to give a person massive blood transfusion? That is the next aspect that we will be starting with. What is massive blood transfusion and what are the different complications that can occur because of it? Having discussed the transfusion protocols, now let's go ahead and discuss something which will help you a lot in medicine and surgery as well, and that is the massive blood transfusion. Firstly, you need to know what exactly defines massive blood transfusion, when do you say or when do you call it massive, and then I'll tell you the complications. So firstly, please note that question number 1 that you'll get, massive blood transfusion means that whatever is the blood volume of the patient, of a human being, if you replace more than 1 time of that blood volume in how much of duration? In 24 hours, that is what you define as a massive blood transfusion. Means more than 1 time of the volume over 1 day. 1, easy na? More than 1 time of the blood volume in under 1 day is how you are going to define the massive blood transfusion. However, if you're not overlooking a patient for an entire day, if for a shorter duration, you have to say that just in case you replace more than 50% or half of it in 4 hours, that is also defined as MBT, massive blood transfusion. Whatever suits you, whatever is the clinical situation, either 1 day or 4 hours. Okay? Now you will ask me that what should be, and remember in this entire topic, this is a thing that you have to know like by heart because you will get a question on it. What is the ratio of 3 components I told you na? Red blood cell, platelets, plasma. So what should be the ratio of these? And they said it should be 1:1:1. Easy to learn, easiest, 1:1:1. So I realize everything in MBT is going to be 1:1:1. That is more than 1 time blood volume exchange in under 1 day, and the ratio is 1:1:1. How simple. But why was it decided that the plasma should be equivalent to the red blood cell, should be equivalent to the platelet? It was decided so because I did not want that, I should have so much of red blood cells, or you should have so much of blood volume that my clotting factors, where are clotting factors present? Fresh frozen plasma, that my clotting factors end up getting diluted, and their level get, if I put too much of blood or too much of water or any fluid into something, things get diluted, isn't it? They would get diluted and my patient would then start bleeding because the levels would falsely become low. That is known as dilutional coagulopathy. We'll talk about it. So basically what we are coming to is known as the complications of MBT. So first and foremost, let's start reading. The patient can have metabolic alkalosis. What do you understand by metabolic alkalosis, and why is alkalosis more common than acidosis? I'll give you a little bit of hint. Tell me, whenever any blood you're using, what is the anticoagulant? You'll say that, ma'am, by now you told us it could be CPDA, it could be SAGM, it could be all these anticoagulants. Remember we did. So when, for example, we are doing CPDA or we are using SAGM, whatever may be the situation, do you know one thing that is there in all the blood products, which is going to be citrate, citric acid, citrate, yes? Don't you feel that when so much of citrate will go into a patient, what is going to happen? There is going to be too much of bicarbonate production, which is going to happen as a compensation. The body says that so much of citrate is coming in, so let me produce a lot of bicarbonate in that process. Yes, because of that bicarbonate, there is going to be an element of metabolic alkalosis that is going to happen. So that is why very, very common in comparison to a metabolic acidosis. Okay? Everyone's understood this. Why? Because we are creating compensatory bicarbonate. On those bases, I can also say, actually I can label this one first. When too much of blood is going into the system, don't you feel the body will end up having a citrate toxicity? If, for example, too much of citrate anticoagulant is going, the body will end up having a citrate toxicity. Hai na? So this is understood as it is. Citrate toxicity means what? Again, think a little logically. Too much of citrate. Too much of citrate. What is the function of citrate? Calcium chelation. So this means there is going to be too much of calcium chelation. Chelation means that what is going to ultimately happen to all the calcium will be extracted. Citrate pulls apart all the calcium, na? That is its function. So what will happen to the calcium levels in the body? The calcium levels in the body are going to decrease. The patient is going to have something known as hypocalcemia, and that is how I have also written hypocalcemia separately. And because of this hypocalcemia, patient is going to have tingling, numbness, these kind of features. So of course you can memorize these as well. So now remember, citrate is causing what? Firstly, citrate can cause cytotoxicity. How? It can cause toxicity. How? By removing all the calcium. So hypocalcemia will be one evident. Also, because of citrate, a lot of bicarbonate production occurs. Body can go into metabolic alkalosis. Last, because there is so much of lysis, now so much of blood will go, there could be lysis also. Lysis could also occur. As a result, patient can also suffer from hyperkalemia. Hyperkalemia means what? There is RBC lysis. So all the potassium is going to come out of the RBCs. So what is going to be the metabolic profile of the patient? Remember, number one, there is an increase in the potassium. Number two, there is a decrease in the calcium. These are all going in continuity. What else? Did I just tell you that these patients could have dilutional coagulopathy? Maybe because the factors end up getting diluted when so many blood products are being given, so much of volume is being given, the factors end up getting diluted, and as a result of which this patient is going to have bleeding. And actually, do you know guys, this is said to be the most common cause of death. This is said to be the most common cause of death. And this, in fact, is said to be the most common cause of death in these patients. Obviously, these patients are going to bleed because, and that is the reason that they're going to result in dying. And that is the reason for what? Or that is the result of what? That is the result of dilutional coagulopathy. One last thing that you have, guys. These patients initially have a spike of hyperglycemia followed by hypoglycemia. Can you make any logic into that? Think logically, what kind of anticoagulants are going in excess? Saline, adenine, glucose, mannitol. When so much of blood is going in the patient, when you're dealing with the case of massive blood transfusion, it's not just blood that is going into the patient, all those preservatives and anticoagulants are also going into the patient, isn't it? So as a result of it, it means that all of these are going to elevate the glucose spike of the patient. There is glucose, mannitol, these will increase the glucose. So initially there is going to be an increase in the glucose, but then who's going to come to your rescue? As soon as the glucose spikes up, the body starts producing a lot of insulin. So as soon as the glucose will spike up, the insulin will suddenly come up and the patient's glucose levels will thereby be decreased. So now you've understood why initially patient has hyperglycemia, because we've put in a lot of glucose in him, and as soon as the insulin comes into play, all of that glucose comes down. So that is hypoglycemia. So finally, what are the complications of MBT? Metabolic alkalosis, dilutional coagulopathy, citrate toxicity, hyperglycemia followed by hypoglycemia, hyperkalemia and hypocalcemia. I'm not giving you any mnemonic for this because I believe that all of you, by putting logic, at least this much of MBT can be totally understood. That wraps up all of our massive blood transfusion. Now we start with the next aspect, and that is known as the transfusion reaction, something that similarly you study in medicine also. So now, two things. What are the different transfusion reactions that the person can have? And secondly, what is going to be the duration of these, and how are you going to work up a patient after that? So firstly, transfusion reaction can either be immediate or it can be delayed. When I say it is immediate, it means number one, the patient could have allergies or anaphylaxis that could be related to any kind of blood product that we have. Any blood product can result in allergies or anaphylaxis. The next one is going to be febrile non-hemolytic transfusion reaction or febrile hemolytic transfusion reaction. And what is the difference between these two? So please note, hemolytic means that there is some kind of a mismatch that has happened. So for example, instead of giving A blood group to the patient, there was a mistake and B blood group was given. So when would that happen most commonly? So this most commonly would occur because of a clerical error. This most commonly would occur due to a clerical error. You get a question that there's a person who's showing transfusion reactions, hemolytic transfusion reactions. Why has that happened? Is it because of some problem in the patient or the donor? No, most commonly is a clerical error. And secondly, this could also occur because of some minor blood groups problems that I'll come to in a while. So that is a mismatch situation that I've come to. That is febrile hemolytic. Hemolytic means the RBCs are going to break, the RBC lysis is going to occur. And guys, you know this. Which kind of a hypersensitivity is it? Go back to your immunology chapter, you've done this. It is a type 2 hypersensitivity reaction. So you know this, very good. After this, the next thing that you come to is known as TRALI. TRALI is something, or before TRALI actually, I would want to cover up the other one also. Let's finish off febrile non-hemolytic transfusion reaction as well. So what's the difference between the two? Kya dekha? In one of them, there was hemolysis. Why was there hemolysis over here? Because A, B blood group mismatch has happened, so the RBCs will break. In the next one, I'm saying there is no hemolysis. This is non-hemolytic transfusion reaction. So let's first do their full forms. Here you have febrile. This means the temperature of the patient is going to go up. Non-hemolytic means it is nothing to do with mismatch of blood and patient's temperature is not gonna go up. And transfusion. So having discussed massive blood transfusion as well as the different complications associated with it, we are now going to start off with the transfusion reactions. When I talk about the transfusion reactions, they are of two types, that is going to be immediate and delayed. Immediate means they are occurring very early on, usually within 24 hours, and delayed are going to occur after that. So please remember, the first one is allergies. Allergies or even anaphylaxis, which could occur with any kind of blood product because allergy is known very commonly in the general population. Second, if you focus, there are two things that I can see. One is, what's the difference? See, TR matlab transfusion reaction, and FF means febrile. So dono mein the febrile, patient's temperature is gonna go up, transfusion reaction hai, but the difference is this is non-hemolytic and this is hemolytic. So first and foremost, I would want to wrap up this one over here. What do you mean by febrile? Patient's temperature is going to go up. Hemolytic transfusion reaction. Hemolytic basically means that the RBC is going to break. Why is the RBC going to get lysed? Why is it going to break? Because there is some element of mismatch that has happened over here. This is due to a mismatch of blood groups. So A blood group person was given B blood group. So antigen-antibody mismatch will happen, right? So the mismatch is basically going to result in RBC lysis. And if you all remember, this was a type 2 hypersensitivity reaction. Go all the way back. that this was a type 2 hypersensitivity reaction that you saw. I hope everyone's okay with it. So the patient is going to come up with fever. There is going to be RBC lysis. I will also tell you in a while how to work up this patient. But yeah, that is FHTR. Whereas now I change one thing. I call it non-hemolytic. When RBCs are not breaking, this means this is not to do with mismatch. This is something else. So what is FNHTR? Again, febrile means the patient's temperature is going to be up. Non-hemolytic means there is no hemolysis that is happening. So febrile non-hemolytic transfusion reaction. Why does this occur? This is going to occur due to, I've told you this a little bit earlier, this is due to massive cytokine release. This in turn is going to occur due to massive cytokine release. And why is that going to happen again? So now who releases cytokines? Can you recall for me? Which cell of the body releases cytokines? RBC, WBC or platelet? It's the WBC, right? So this is going to be massive cytokine release from the white blood cell. So you will now ask me that how can I prevent it? So now tell me, if you know the culprit is white blood cell, remove the culprit. You know the culprit is white blood cell. Do you know how to remove the white blood cells from the red blood cells? Do you remember that filter that we had? So please remember, we are going to give leuko-reduced red blood cells to the patient. How do we reduce the WBCs? There is a filter. All of us have seen that bag. We are well versed with it, that if you remove the white blood cells, you will not have cytokine release. So if no white blood cells are there, no cytokine release, no febrile non-hemolytic transfusion reaction shall occur. Everyone's okay with this? So the reason is cytokine from WBC. The prevention is remove the WBCs. That's how you can do it. Okay, coming to the next one. What is TRALI? This is quite famous with students and examiners. So firstly, what is the full form of TRALI that we are understanding, and why is it immediate? I'm calling it under an immediate reaction. So firstly, transfusion, of course, I'm talking about transfusion. So it is a transfusion related. ALI to padha hai, you have already studied it way back. Acute lung injury, you have studied all of this in the respiratory chapter. That is transfusion related acute lung injury. So now tell me something, where did you study acute lung injury? Dekho, isme bhi word acute is coming, means this process is happening within 6 hours. Transfusion related acute lung injury. So where have you studied? This was that ARDS. This was adult respiratory acute respiratory or adult respiratory distress syndrome. Yaad hai? Remember that? It was also known as something else. It had hyaline membranes. It had hyaline membranes which were forming in the lungs. So what kind of edema was happening in these patients? There was basically non-cardiogenic pulmonary edema. I hope everyone remembers this entire pathogenesis, which was huge, and we studied it in too much of depth. What is it? Non-cardiogenic pulmonary edema is what is going to be there with TRALI. TRALI because it is an acute lung injury. So the question coming to your mind is that why is all of this happening? So please remember, this is an immune mechanism. What immune mechanism am I talking about? It is anti-HLA antibodies. Who has anti-HLA antibodies? The donor has anti-HLA antibodies, which are going to react with obviously the HLA antigen of whom? The HLA antigen of the recipient. So tell me one thing, I am saying that the main problem is that the blood that is coming to me, the blood that is coming to the patient, that blood has a lot of antibodies, which anti-HLA antibodies, and antibodies are present in which part of the blood? Maximally, antibodies are in the plasma, na? So don't you feel that the donor plasma is going to create a problem? Don't you feel this is maximally associated with fresh frozen plasma? And you understand the reason why? Because fresh frozen plasma is basically going to have a lot of anti-HLA antibodies. So whatever, if I am the patient, for example, if blood is being given to me, whatever HLA antibodies will come, they will react with my antigen. So antigen antibody reaction hua and the lung is gonna get affected. There is non-cardiogenic pulmonary edema or hyaline membrane, or you can call it acute lung injury or ARDS. They all mean the same. The concept is that it is because of anti-HLA antibody. So how do you prevent it? You will have to basically, you know, over here you really can't help it. You will have to decrease the transfusion rate. So please note that when you are dealing with a case of TRALI, firstly, because why am I making this list over here? Because as I will tell you about TRALI, I am now going to correlate it with a condition called TACO, and this is one of the most common doubts that students write to me, ma'am, TRALI, TACO, can you tell us the difference? So firstly, TRALI ka full form to you know na, it is transfusion associated or transfusion related acute lung injury. Whereas what is TACO, guys? It is transfusion associated circulatory overload. It is transfusion associated circulatory overload. So first, please tell me what are the underlying mechanisms of these. So over here I can see this is associated with what? This is an antibody associated thing. There are anti-HLA antibodies that are present. Whereas transfusion associated circulatory overload. Why is a circulatory overload happening in the patient? Because there is some pre-existing comorbidity that the patient has. So for example, you have a patient of cardiac heart, congestive heart failure or a heart failure. So there's a congestive heart failure. If you give too much of blood to that person, will he end up in a circulatory overload? Yes. Or maybe there is a pregnant female in her third trimester. There's a pregnancy which is occurring or which is currently in the third trimester. Again, if you give her too much of blood products too quickly, she will end up with a circulatory overload. So please remember that if there's any pre-existing comorbidity that the patient has, that is when this TACO can probably occur. So how is the patient, or what are the parameters going to be that will help me differentiate between the two? Please note, in TRALI, when we talk about these three parameters, that is the blood pressure, the jugular venous pressure, and the BNP. So all of these are either going to be normal, and more or less they're going to be normal only. Sometimes the BP on the other hand can even patient, because of acute lung injury, you can see acute lung injury hoga, hyaline membranes will form, lungs are totally going to get affected, oxygen exchange will not occur. So sometimes because of hypoxemia also the patient can have deranged parameters, but most of the times there is going to be a normal BP, normal JVP, normal BNP. Sometimes the patient can enter into a state of shock following hypoxemia and all, wo ho sakta hai, but more or less common is normal scenario. On the other hand, when I'm talking about TACO, the BP is elevated, the JVP is elevated, and the BNP marker, which is very important, that is also elevated. So please note that this is exactly what you're gonna see in a case of TRALI versus TACO. Very, very important. TRALI versus TACO. TRALI was because of anti-HLA antibodies, and TACO is associated with some or the other pre-existing condition. I hope everyone's okay with this. We are done with TRALI and TACO, and we are done with the immediate disorders. TACO, on the other hand, can come as a delayed disorder also. Okay? Now, what are the other delayed disorders that I have? So, firstly, I can see there is a delayed hemolytic transfusion reaction. You'll say, wait a second, ma'am. Right now, you had one hemolytic transfusion reaction which was occurring early on, because what kind of mismatch did I tell you over there? Main blood groups wala, A blood group, B blood group, AB blood group, O blood group, the AB, ABO, main mismatch I told you. However, for the minor blood groups, like if there is a mismatch of say minor blood groups like Kell or Duffy or Louis or all those chota wala blood groups, those are going to result in a delayed hemolytic transfusion reaction. Is that okay? Coming to the next, there can be something called PTP. What is PTP? Post-transfusion purpura. Now just put a logic into it. Post-transfusion, you're understanding after blood transfusion. Okay. What do you understand by purpura? Purpura is the red color rash that occurs on the skin. So tell me something. When does someone have purpura? What count in the body? Like dengue fever, have you heard patient has purpura because platelets reduce, hai na? So over here also, if post-transfusion purpura is happening, this means the platelets are getting affected. So basically, there are anti-platelet antibodies that are forming, and this is going to occur usually after 7 to 10 days. Your body needs time to start making antibodies. Time lagega. That's not going to happen in 6 or 12 or 24 hours. It's going to take time. And these are usually which are antibodies against the GP3A receptors. This is something I'm telling you for the higher institute exams. Please remember, there could be antibodies against the GP3A receptors. What is next? These patients could have GVHT. I guess all of us have already studied GVHT way back in our immunology chapter. So now over here, because this is not the GVHD which I studied there, over there I studied GVHD with kidney transplant, bone marrow transplant. Here no transplant is occurring. Here transfusion is occurring. So here I'm talking about transfusion associated graft versus host disease. Transfusion associated graft versus host disease, and the concept is the same. What was the underlying mechanism? Let's take a quick test. You're on the end of the pathology, so you need to know the beginning of the pathology. Of course, kya tha mechanism? You had a donor and you had a recipient, and there was immunity discrepancy between the two. I said the donor was very, very powerful, that the donor was immunocompetent. The donor was immunocompetent and the recipient was very, very weak, means the recipient was immunocompromised. So you say that, for example, ma'am, now how do I fit that situation in this situation? I will say that I am undergoing a blood transfusion. There is one donor and one recipient. So donor to is very, very strong. The donor is very, very strong. He has good immunity, good blood, but this recipient was, say, HIV positive or some other immunocompromised person. So don't you think the donor will go and end up attacking the T cells of the donor will go and end up attacking this poor recipient? Yes, that is what is graft versus host disease. Next question. In graft versus host disease, what are the organs that were damaged? If you remember, the cell organs were damaged. Everything we have studied earlier, we had said that the skin and the GIT mein kya? That is going to be intestine is affected and the liver is affected. So how would you have presentation of the patient? So skin affected hoga, patient will have rash, intestine affected hoga, patient will have diarrhea, and liver will be affected, patient will have jaundice. Of course, there is no other presentation that I can think of. Easy, na? So SIL was affected there also. Your last question would be, how do you prevent it? Now you know that if you know the cause, then treat the cause. Now, you know the cause is that this donor is trying to act very smart. This recipient of mine is very, very poor and immunocompromised. And this donor is trying to act very, very smart over here. So let me just remove the donor T cells, the smartness. Let me just remove the smartness. So I am now going to give irradiated blood. I am going to give irradiated blood. That is a procedure known as gamma radiation. That is a procedure known as gamma radiation, in which basically I will remove all these T cells which are trying to act smart. I will say, okay, wait, hang on, I will remove you. How will you act smart after that? So gamma radiation or irradiated blood can prevent graft versus host disease. Coming all the way back, the last part that we are left with is certain infections can also occur. Let me ask you a common sense wala question over here. Tell me one thing, infection will occur with which blood product? Red blood cell, platelets, or plasma? Firstly, you will say, hang on ma'am, what infections are you talking about? Are you talking about HIV, hepatitis and all of those? No, those have already been screened. If you remember, the fact that you are giving the patient blood means you have tested for those 5 infections: HIV, hepatitis B, hepatitis C, malaria and syphilis. Those have been tested. I am not saying that after testing also my patient is going to develop those. I am saying that there is a risk of infections because maybe in your blood bank the blood got contaminated. Maybe there was an element of blood contamination. Some bacteria, virus started growing into the blood. So please tell me which blood product is at a risk of blood contamination. So think which blood product is, revise the temperatures jaldi. RBCs, you will say, ma'am, RBCs to refrigerator mein tha, that was 2 to 6 degrees centigrade. I don't think bacteria will grow at this temperature. Fresh frozen plasma to was -30, less than -30. That is also not going to have bacterial contamination. But this platelet rich plasma, that was at quite a high temperature, 20 to 24 degrees centigrade it was at. Bacteria ke liye to this is the most happy temperature to grow at. So maximum risk of infections or maximum risk of contamination is with platelet rich plasma because they are at quite a high temperature of 20 to 24 degree centigrade. So what are the infections that are possible? Yersinia enterocolitica infections have been seen. Yersinia enterocolitica infections have been seen. Other than that, E. coli, Pseudomonas, they also tend to infect the cells. So please remember, these are very common infections or contamination that can be seen usually with PRP at a temperature of 20 to 24 degrees centigrade. So on that note, if you look back and study the transfusion reactions, you have done those. But now, whatever may be the transfusion reaction, imagine you are in the blood bank. Now just imagine yourself as a blood bank officer. Now you realize, or you get a call from the clinic, from the surgery OT or from the surgery OPD or from the surgery wards, and they say, we were giving 1 unit of blood transfusion, suddenly my patient has fever and chills, febrile hai. So you were like, okay, is he passing blood in the urine? They were like, yeah, we can see a few drops of blood in the urine. You say, first and foremost, in case there is, please note, in case there is a transfusion reaction, what is it that you have to do as a protocol? First and foremost, you instruct them, stop the transfusion right away. stop the blood transfusion stat immediately. Second, you ask for 3 samples, and I'll tell you what are those 3 samples. First, you say, I need a blood sample. And second, you need say, I need a urine sample. So, ये तो 2 samples हुए. Why am I saying 3? So, I'll tell you. Why do you need a urine sample? Because you want to test for hemoglobinuria. Or in other words, you just want to find out that is the patient having a hemolytic wala transfusion reaction or a non-hemolytic. You've understood the difference na now? Hemolysis means कोई AB blood group mismatch हुआ है. Non-hemolytic basically means that maybe it is something to do with cytokines or allergies or some other reason. So, you will first want to find out the urine sample to know whether hemolysis is present or not, whether hemoglobinuria is present or not. When you're talking about a blood sample, you will take one blood sample that will come in an EDTA vial. EDTA vacutainer basically means this is the blood sample that you will use for BGCM. What is BGCM that you call in blood bank? BGCM is blood grouping cross matching. You will check again, kuch galti to nahi hua tha? Did I make a mistake? Is the blood group of the patient genuinely A positive only? What I thought earlier is A positive. You're going to do a blood grouping cross matching. On the other hand, you're also going to see it in a plain red color vial. You will tell them, send me one more blood sample in a plain red color vial, because from this I want to do some biochemical tests. I want to do some biochemical tests again in order to find out about the hemolysis part of it. So please note once again, you are going to ask for 3 total samples. 2 of them are blood samples, one in an EDTA vial, one in a plain vial. The second one is going to be urine sample to check for hemolysis. And meanwhile, you've told them, please stop the blood transfusion, let me work up this patient, let me get back to you and let me find out what exactly has the problem occurred. That is your usual protocol that you follow for TRs, transfusion reactions. Now we're done with this concept. What is the next part that we have to study? It's a recent 10th edition update. Robbins 10th edition has added this particular concept known as ABT, autologous blood transfusion. The name is pretty interesting, na? Blood transfusion to I have studied a million times. What is the meaning of this autologous? Autologous means giving blood to my own self. Firstly, why would I do that? I think it's one of the best things to do. Because if I give, now just think logically, if I give blood to my own self, do I have a risk of getting HIV or HBS or HCV from my own self? No. Do I have a risk of getting any other infection? Do I have a risk of getting allergies from my own self? No. Do I have a risk of any GVHD, any other PTP? No, all those reactions suddenly vanish. So I think it's such a nice thing to be able to give blood to our own selves. So there are 2 things. Firstly, I should be physically fit to give blood to my own self, and secondly, how all can this procedure be done? So firstly, note there is something called PAD, ANH and cell salvage, out of which PAD is most common, most practical, I would say. ANH is being done in some centers like AIMS, not many centers, but there are some centers who are practicing it. Cell salvage is very, very difficult, mostly for research, very, very expensive. But yeah, I'll make you well versed with all 3 of these. Firstly, what is PAD? Pre-operative autologous blood donation. So what I want you to do, divide a patient's journey of a surgery into 3 parts. Okay? First part is, so just think there's a female. Let's consider, guys, there's a female. Clinically dekhte hain. Let's look at the clinical part. Here you have a female and she has a surgery. Nothing to write in this. Okay, this is just a story. You don't have to write anything. So what is this? This is going to be a surgery. She is being surgically removed leiomyomas. Okay? So surgeon and gynecologist are talking. Acha, she has leiomyomas. So this is not a medical emergency. We can give her a date for an elective surgery. She has said that I want to get it removed as per my schedule. I'm very busy. So I will get it removed after 3.5 weeks. She has said I will come after 3.5 weeks and I will get my leiomyomas removed, or whatever surgery is being done, maybe a hysterectomy is being done. So she has given you a date after 3.5 weeks. Okay, you said till then please get your pre-anesthetic checkup done. We want to know whether you're physically fit or not. Her hemoglobin has come out to be somewhere around say 11.5. Now that is 12 से less है, yes, it is borderline, but she's not having any symptoms. But you are saying, the gynecologist is saying that, sir, I could have leiomyoma surgery hai, there could be an element of bleeding that she could have during the surgery. During the surgery, she could have a bleeding. So what am I going to do? I will tell her that, listen, your surgery is after 3.5 weeks. Now, why don't you donate 1 unit of blood today? Why don't you donate 1 unit of blood today? 1 unit blood transfusion. That is how you write. The O with the dot is a unit. So So you tell her, why don't you give blood, 1 unit blood? We will keep your blood, and then after 3.5 weeks, if in surgery you feel anyway your blood will replenish till then, and during surgery if you have blood loss, we could give you your own blood. There is no problem of blood grouping or any reactions that will occur. You will end up getting your own blood. So sounds like a good deal, but when could you do that? You've done this way behind the surgery. Pre-operative autologous donation, much before the surgery you have done this. This was scenario number 1. Now let's consider scenario number 2. This was not done, for example. Pre-operative, so first I'll tell you, this was known as pre-operative autologous blood donation, PAD. So this means the blood is collected well before, in advance, before some elective surgery. Now if elective surgery ka situation nahi tha, right now your patient is in the OT. Now let's look at the next one. Let's look at what is ANH. So please note right now, so how have I learned ANH? ANH ka full form and all I will tell you. I have learned ANH as anesthesia ke baad. So what are you doing? Now this female says that I am in the OT. I am in the OT now. Today is my surgery. You say that, surgery has not started yet, but I feel she's going to have blood loss. What can I do? Hemoglobin bhi theek hai abhi to. What am I going to do? I am going to give her anesthesia. Anesthesia de do. That is why I said AN. Anesthesia ho gaya. Anesthesia ho gaya, but before the surgery, before you start the surgery, you are gonna begin, or you're gonna take 1 unit of blood. So this is something like drugging a person and getting something out of him. So that is something like that, only it sounds like that. So what do? Blood is collected immediately after anesthesia. You give anesthesia and before the surgery. So don't you think that's a very risky thing to do? You've given the anesthesia and before doing the surgery, you take 350 ml of blood. Are you playing with the volume of the patient's blood volume, overall body volume? So don't you think you need to replace it with some kind of crystalloid or colloid, some artificial blood, so that overall blood volume remains the same? Yeah, that you will do. You are basically going to replace, you're going to replace it with some kind of normovolemic sample. Now read the name again, guys. Acute normovolemic hemodilution. That means what? That I am taking blood from this patient, hemo I am taking, but I am diluting it by making it normal volume. How am I making her a normal volume? By giving her some element of colloid or crystalloid, which is also known as artificial blood. Okay, everyone's understood the ratta way also how to learn it. ANH matlab anesthesia ho gaya. After giving anesthesia, before doing the surgery, you're going to take 1 unit of blood, and if she will need surgery mein blood, you will give it to her. Coming to the last scenario, you say, ma'am, anesthesia also done. Anesthesia is done, the surgery has also starting, the gynecologist and the surgeon are cutting things, fascia is being cut, blood is being cut, vessels are being cut, capillaries, veins, everything is being cut. Is there an element of blood loss that is happening during the surgery? Repeating again, during the surgery has already started. Whatever blood loss is happening, you say, let me save that. What is that known as? Cell salvage. Whatever blood is collected intraoperatively. So do you think that's going to be pure blood? Like when the surgeon is doing a surgery, is he or she only cutting the blood vessels? No, na? Fascia, tissue, debris, fat, everything is being cut with a scalpel. So whatever loss is happening in that drain, the drain that is attached to keep the surgical field free, whatever drain may things are going, it's not just blood. Blood is mixed with tissue, fascia, fat, maybe muscle tissue bits. So can you say that I can take that blood and just give it as it is back? No, you will have to filter. There has to be a filtration process that needs to be done. You will have to remove all the tissue, the debris, the fat and everything and get pure blood. Isn't it sounding A, complicated, B, damn expensive? Because you'll have to have a huge machine, and in the surgery, patient needs blood. You have to do that process very quickly. A very expensive machine is needed for all of that. So this is not sounding as practical as we think that this technique might be, right? So now we have 3 methods of autologous blood transfusion. Either one is well before the surgery, elective surgery case, pre-operative. Second is anesthesia ho gaya, after anesthesia, before the surgery. And third is during the surgery. PAD is the most common. Practical bhi hai. ANH is also being done in many higher centers like AIMS, and cell salvage is kind of tough to do, so it's more of research. Okay, that makes it ABT also done. What is the next thing? The next thing that we have to study is a machine that was always important, but in COVID it became super duper important. So that was, what is this machine, guys? This is the apheresis machine. This is referred to as the apheresis machine. So now, many people, some people call it platelet apheresis machine, some people call it plasma apheresis machine, whatever kind of apheresis machine you wish to call it. I'll tell you why you will do that difference. So what do you have over here? Here you have a donor. And from this donor, all of you can see that the blood has been taken. So can you see from his arm, the blood is currently being taken and is being put inside this machine. So firstly, get a hang of what is this machine. This machine is basically the inside of this. This is a platelet or just an apheresis machine for the time being. Okay? It looks like like one of those NASA ka tables where there are so many, rocket science kind of things there, so many knobs and buttons and bags hanging. So this seems to be quite interesting. It's genuine, and just like a trolley, it has wheels. You can move it around in any room of the blood bank. So yeah, but although it's portable, but you can see it's got some really, really advanced things. Now, firstly, you'll ask me, why are so many bags hanging? Because it's a live process going on. You have taken blood from this patient. You have taken blood from this donor actually. And while he is lying down in front of you, you have separated. Can you see the blood has been separated also? Ye red wala must be red blood cells, one must be platelet, one must be fresh frozen plasma. You have separated the red blood cell and the platelet and the fresh frozen plasma. Why have you separated it? Because whatever component is needed, you will keep it. So for example, you say that, ma'am, I am doing platelet apheresis. Matlab, I am in need of what? I am a blood bank officer. I know that there is a dengue outbreak that has happened in Delhi. Every second patient is having dengue, means every second patient is in need of platelets. I know that right now the maximum demand in my blood bank is going to be of platelets. So why should I take my donor's pura blood? I will say, listen, I just want your platelets. So I will keep the platelets. So for example, I decide I will keep the platelets, and what will I return to the donor? Can you see from another route, you are returning, you say platelet chahiye, I have kept the platelets, I don't need the red blood cells in the plasma, I will return it to you. Why should I take unnecessary things from you? So basic is that whatever naming is done means that is the component that the blood bank has kept. So when I say platelet apheresis, blood bank has kept the platelets, rest everything has been returned to the donor, transfused back, given back to the body. When did this become very famous? In COVID, because in COVID we did plasma apheresis. In COVID, there was plasma apheresis. So please note that plasma apheresis means we kept the plasma. Why did we keep the plasma? Because we were interested in patients from COVID, recovery patients, the COVID warriors who had antibodies. You wanted those antibodies so that you could treat other COVID patients, right? Although later on they said that, although this was like a big hype for 6 months, everyone was undergoing plasma apheresis for people who had, suffered from COVID, who had recovered from COVID. But later on, everyone realized that this was not having much of a role. So it was stopped after that. But yeah, plasma apheresis means plasma rakh liya. Why? Because it will have antibodies and that I can use. Platelet apheresis means it's I've kept the platelets. So whatever you keep, you call it as per that. Everyone's understood this? I hope yes. Fine. All said and done. What is it that you're going to study now? Can you answer this question? Diagnose the blood group. So the blood group is what? What did I teach you? You had to look out for where all the agglutination is happening. Sabse pehle you had to look at control. Control had to be what? Control had to be clean. So yeah, it is clean over here. Very good. After that, you had to see what? You had to see anti-A, anti-B, anti-D. Anti-A mein to agglutination is there, anti-D mein agglutination is there, B mein it's not there. So what is the blood group? The blood group is going to be A positive, A positive. Very good. Moving on to the next question. Name the technique of blood grouping as shown in the image below. Is this a tube test or a slide test or a gel cord or an ELISA? I really hope such questions come in your paper. I mean, so nice. You have a nice little ELISA plate in front of you. You know this is ELISA for blood group. Do you remember how many wells does an ELISA plate have? This side it has 12 and this side it has 8. So total how many wells? It has 96 wells, and that's an ELISA plate that you use universally, whether it is in path, micro or biochem. ELISA plate looks exactly like this. Moving on to the next question. What is this technique? Name the technique for blood grouping that has been shown over here. So yahan to simple technique pucha hai. All of you know this card with the gel is definitely known as the very, very famous the gel card technique. So isme to I don't think there was going to be any problem. But the next question is that on this gel card technique, what is the blood group? Now, you know it's a gel card. You have to diagnose the blood group. So what can you see over here? What was the gel card ka mnemonic I told you? That whenever you get a line on the top, you're going to call it positive. And whenever you get a line niche, bottom, you're going to call it negative. So remember, when you get a line on the top, that is positive, niche, negative. So this means top pe line hai positive, bottom hai negative. Top pe line hai positive, control to has to be negative only. So what is going to be the blood group? A is looking positive, D is looking positive. Blood group is going to be A positive. So top is positive, negative is niche. Moving on to the next question. Match the image with the correct option. What do you see over here? I just showed you this machine. This is the very, very famous apheresis machine. Could it be platelet apheresis or plasma apheresis? That depends on my demand. Moving on to the next question. I'm showing you lots of images. You need to match whatever you feel. So what is this, guys? Firstly, you know these are all bags. Okay, so is this a platelet agitator? No. Leuko-reduced. For that, I need a filter. Do you see a filter over here? No. Penta. Penta was PE, Penta, PE, pediatric. Is this for pediatric? Are all the bags chota baby bags? No, this is also not Penta. So either it is a top and bottom. Either it is a tap means top and bottom bag, or it is a tat bag which is top and top bag. So now I have to look at the tubings. I can see tubings on the top, I can see tubings on the bottom. So the answer is very clear to me. It is a top and bottom bag. How easy is that? One more matching. Now the same options. Can you match this? I can see this is a machine and this is that platelet wala machine, the machine that goes left, right, keeps agitating. So what is this going to be? This is going to be a platelet agitator. Very, very good. Let's move on to the next. Which cells agglutinate most strongly with Eulex europaeus lectin? Guys, do you remember what was Eulex europaeus lectin? It was anti-H. So you need to tell me which agglutinate most strongly, who has maximum H substance. Do you remember who has maximum H? O blood group. So O to hona chahiye, that should definitely be there. And after O blood group, if you write, it was A2. A2 ke baad it was, yes, it was B. Then it was A2B. Then it was A1B. And finally, or in other words, that is how you had to go ahead with it. So simple, yeah, A1 alag and then A1B alag. That can also be there. So on that note, please note that O and A2 are going to be the ones which are going to agglutinate most strongly with anti-H, because O has the maximum associated H antigen present. Let's move on to the last question of blood banking. The following peripheral smear finding is noted in a patient suffering from. Pehle to stop here. Can you tell me what is the peripheral finding? I see over here that there are a lot of spikes. The red blood cells have a lot of spikes like this. What is that spiky cell known as? It is known as a spiky spur acanthocyte. So the red blood cells are showing me acanthocytes. So next, the patient has involuntary movement, jerking motions of the arms and the legs, muscle tensing of the face and the throat is noted. And there is, on genetic analysis, the following blood group system dysfunction would correlate with it. So what all do I see? Do you see some element of neurological involvement? Then you see some element of acanthosis. So what is neuroacanthosis syndrome, which is also known as the Macleod phenotype? What is neuroacanthosis, which is also known as the Macleod phenotype? And that is going to be the Kell system of blood group. That is referred to as the Kell system of blood group. Very, very important. Yes, on that note,